last session of this summer course. We'll finish off with some topics that may be of interest to you, and some new information. Some might not be very new, but I hope you'll just bear with us. We'll go through first on macular diseases, and later we'll talk about something about the vitreoretinal approach to lens and IOL problems. Well, as far as macular surgery is concerned, macular diseases and macular surgery is concerned, I think over the last 10 to 15 years, purely because of the great advance we have in technology, like of course we all know what the difference the OCT has made to our clinical practice, and also our ability to deal with macular diseases like active retinal membranes and macular surgery and macular holes, because of the advances in vitreoretinal surgery and surgical techniques. So I'd just like to introduce a little bit about what we know today of macular diseases. Although even up to today we don't know why certain macular surgical diseases, we know why the AMD, DME, all those it's quite well worked out in terms of the pathophysiology, but in terms of surgical macular diseases, largely we don't know the exact cause, although it's been described as far back as 1869, and the pathophysiology, if you look at the literature, it has been described and studied by many famous clinicians and scientists alike, and it's been reported a lot in the literature. So what is the relationship between the vitreous and the macula? Right? We know what the relationship it is to the entire retina, but specifically why does the macula becomes a source of disease as a result of vitreous changes. Okay? So because diseases that affect the vitreous, and particularly it is the vitreoretinal interface, right? It's not the body of the vitreous, it is not the anterior hyaloid, it's basically the posterior hyaloid, and that can cause a variety of macular lesions that can affect vision, especially central vision in the form of distortion of vision, metropopsia, loss of visual acuity, central scotomas. Okay? And basically, macular diseases arise mainly from the incomplete and the abnormal separation of the posterior hyaloid and the macula. So if that happens, then there is a chance that it might lead to macular, vitreomacular interface diseases. And now we term these conditions as the diseases of the vitreomacular interface, or VMI. You'll hear that in meetings, and you read the literature, and read the journals, you'll see a lot of this term being used. And the main reason that occurs is because of anomalous posterior vitreous detachment, or what we call APVD. This morning we heard about PVD, PVD being a very natural occurrence as a result of aging, pre-senile diseases like high myopia, all these cause PVD. So normal PVD is the ideal situation, okay, when there is a complete loss of vitreoretinal adhesion or adherence. So if that happens to everybody all the time, then we will have very, very little problems with the macula. So anomalous PVD occurs when there is an imbalance between the vitreous syneresis or imperfection and loss of this vitreoretinal adhesion that results in traction on the retina, either in peripheral retina or in the macula. Right? So in the peripheral retina, we know that it obviously causes retinal breaks, U-shaped tears. If this doesn't if it doesn't occur naturally in the macula, then it will cause diseases in the macula. Right? We heard this morning it causes retinal hemorrhages, and of course that could lead to tears, and that could predispose to retinal detachment. It happens as a part of the disease process in proliferative diabetic retinopathy. That's why you get tractional retinal detachment. That's why you have vitreous hemorrhage in proliferative diabetic retinopathy. And in a lot of conditions that affect the macula, especially in terms of macular pucker, macular holes, and vitreomacular infection, is because of this incomplete separation that gives rise to this condition known as vitreous schisis. So you have many layers areas of splitting within the vitreous itself, even before it affects the macula. So anomalous posterior vitreous detachment. So vitreomacular pathology is synonymous with anomalous posterior vitreous detachment, and that results in persistent vitreous traction on the fovea or on the optic disc. It results in secondary epiretinal avascular proliferation. You will see cellular proliferation in terms of glial cells, astrocytes, and these, with time, result in anatomic retinal changes. Retinal changes are related to retinal distortion, thickening of the retina, intraretinal cyst formation. Sometimes you will see subretinal fluid if the traction is severe, schisis, or splitting of the inner and outer layers of the retina, depending on the type of retinal that's affected, and it's associated at the end of all these processes, sometimes with macular hole formation, could be a lamellar macular hole, full thickness macular hole. So almost all acquired vitreomacular interface pathology is a result of anomaly in the normal aging vitreous. Right? And we know that there are two processes that occur with age. One is progressive vitreous liquefaction and progressive weakening of the vitreoretinal adhesion. And the main chemical, the main components are affected are collagen, fibronectin, and also preglaminin. So the three components. So an international panel in 2012 was convened to devise a new classification system for diseases of the vitreomacular interface. And this is a strictly anatomic and OCT-based classification. It's not based on visual acuity. It's not based on patient symptoms. It's not based on what clinical findings were found. And it's an objective grading based on OCT. Right? So that we can then speak one common language, which is simple, easy to use, and we can use that to predict outcomes of therapy or treatment with surgery either, or with oncologic agents, as we will find out later. So basically you have both, then you have one system where you can completely assess. And basically this panel was tasked to look at it from an OCT point of view, because as we all know, over the last 10 to 15 years, the OCT revolution in terms of being able to have an image or where we can see all the entire from the retina to the RPE to the choroid, in one simple scan, non-invasive method. Okay, that is simple and it's applicable to the majority of cases. So again, why the back interest in 2013 is because we have findings that are new, based on, of course, nowadays we all don't talk about time domain, we all talk about spectral domain in terms of resolution and quality of the OCT. That's why we can then better understand the pathogenesis, because then you can do serial scans, you can follow patients through, and then you can see what progress is made. And you can then correlate the surgical outcomes to OCT findings in terms of success or failure. Right? And this classification system then allows us, like I said, to speak a common language. And because there was at that time oncoming new therapies that are becoming possible for vitreomacular disease in terms of pharmacologic agents, much like anti-VEGF, vitreolytic agents as well. So for the first time, we can see what we actually see clinically as a sheet, a gray area, then translated into a OCT image, which you can even make it into three-dimensional and turn it around and look at it in a different way. And similarly for macular holes, again, you can understand, link that to the pathogenesis. Why did the macular hole develop? Purely because of vitreoretinal adhesion. So the International Vitreomacular Traction Study Group classification of vitreomacular adhesion, traction, and macular hole was published in 2013. You can read it, but I will just summarize the main findings, the main reports. of this classification system. So common to all the VMIs is this finding. That means if you scan all these eyes, they have what we call vitreomacular adhesion. So vitreomacular adhesion is common to all these VMI diseases, right? And the progression of this adhesion into either a vitreomacular traction, a full thickness macular hole, a lamellar macular hole, or an epiretinal membrane, then you can qualify based on what you find on the OCT. Okay? So VMI classification of vitreomacular adhesion is that it is purely a OCT finding, and there is no symptoms that the patient will present, no clinical changes that you can see clinically. And then if you scan the retina, it must be present in at least one OCT-based B scan through the fovea. And essentially, it just represents an area, perifoveal area of posterior vitreous. That means the separation has not completed. Okay? And it's, again, a age-related syneretic change. It's not pathologic, it's very common. And you will see this line above the surface of the retina, and that will be the vitreomacular adhesion. And you can see a completely normal retinal architecture, right? So there is perifoveal PVD. Right? So this adhesion can be classified as focal or broad, and they have chosen around 1,500 microns. If it is a focal adhesion, means it is less than 1, the adhesion is less than 1,500, and if it is a broad adhesion, if it is more than 1,500. Right? So there is a known, why 1,500? Because histologically, we have already studied that, and there is a strong area of vitreomacular adhesion around 1,500. And this is the pre-existing cutoff, employed mainly by the reading center, so that we can all come to one single language in that sense. So again, examples of focal, VMA, and a broad VMA. Okay. So VMA can be concurrent or isolated. So basically, is it just an isolated finding in the absence of posterior segment disease, or is it concurrent with posterior segment disease? All right. So this VMA may or may not be attributable to this concurrent disease, for example, frequent epithelial detachment or central serous retinopathy, right? So visual effects of this condition, if present, is maybe due to the VMA itself, rarely, but usually due to the secondary disease. Okay? So when does vitreomacular traction occur? So when vitreomacular adhesion progresses, posterior vitreous cortex then becomes visible again on the posterior surface of the retina, and there is a detachment of the hyaloid at some point in the perifoveal area with anatomic changes in the retina. So now you will see that there is retinal change, and the retinal change is in the form of a elevation of the retina, and it is almost always pathologic. It is always pathologic, but may or may not be symptomatic. So some patients with milder forms of vitreomacular traction may report no visual disturbance. Okay. And there is all right. So vitreomacular traction is VMT, is VMA with any abnormal macular surface retinal architecture. You can see the architecture of the retina is changing. So you classify that as vitreomacular traction. And again, it is a OCT diagnosis, so it doesn't matter whether the patient has symptoms, whether there's metamorphopsia or loss of vision. Okay? So when VMA becomes symptomatic, then it translates into vitreomacular traction. Okay? So you can see that the natural progression of vitreomacular traction can occur with spontaneous posterior vitreous. That means the traction can actually separate on its own if you follow the natural history. And usually with that, the patients, if had symptoms originally, you'll find that they become regression. The symptoms regress. Sometimes you may have cystoid spaces, and then subsequently it might result in epiretinal membrane formation, but there is no more traction, right? Or it could just remain the same, and it's, as in this picture, it just remains like that. So every time you see the patient, it remains the same for years. or it might actually progress to anatomic distortion with full thickness macular hole or with lamellar macular hole. Okay. So most patients with VMT good vision and mild to moderate symptoms, you can just observe them for 3 months and then re-examine again 3 to 6 monthly with the OCT and see which group they fall into. It's hard to predict, actually. I've never been able to predict. Some patients you think they will never get better, but one day it's gone. Some patients you think it's you first follow them and then they always look the same. Okay? So you can ask them to perform a self-examination and then test them again each time. What are macular holes? All right. So the sub-classification of vitreomacular, if it progresses to macular hole formation. So in the old classification, we know 1, 2, 3, 4. Okay. So basically, in the new classification, VMA is actually stage 0. It means there is no hole formation. The vitreous is adhered. There is a vitreomacular adherence. Okay. Second, in stage 1, obviously, it will be some form of vitreomacular traction. You know that in stage 1, there is a perifocal ring, as described down there. Okay. And in in between, where there is no posterior vitreous attachment, then you have vitreomacular traction. Again, it is still a form of traction, but usually more severe. So you get a bigger hole and more severe traction. And if the VMT is released and there is a full thickness macular hole, then it corresponds to what was known as stage 4 in the past. So basically, the full thickness macular hole classification under the new BMI. So as I said, the old classification, stage 0. Now we know that it is probably what we call VMA. Stage 1, of course, VMT, and then full thickness macular hole, stage 2 and 3, depending on the size. Because in the new classification, it is the size that is important, and that predicts the success of pharmacologic treatment or surgical treatment. Okay? And of course, in stage 4, it's a complete PVD with a large macular hole. So that is the whole stage 4. So in terms of full thickness macular hole, the size does matter. Okay? The bigger it is, the more changes there are. Small thickness macular holes are classified as being less than 250 microns, medium between 250 to 400 microns, and large is anything below greater than 400 microns. Okay. So it is the size, but not the stage, that is critical for surgical outcome, not only in terms of pharmacologic treatment, but also in terms of surgical treatment. Okay. So aperture size, as you know, is based on the OCT caliper measurement. You measure the smallest, the narrowest width of the macular hole, not the biggest one, the narrowest one, right? And you don't measure you measure around the middle or the outer part of that, not at the inner part. Right? So this will be classified as a small hole, less than 250 microns, and this is the base. That is really small, sure. No? This is moderate. Going towards large, already 390 microns is the borderline. And of course, anything beyond that, this is going to be 400 microns. Okay. So again, OCT is important if we look at macular holes in fellow eyes. Of course, if you have already macular hole in one eye and there's no VMA in the fellow eye, then the risk of having a macular hole is much smaller, right? Naturally, because if already the vitreous is separated, you can tell a patient that's good, you have a very low risk of having a contralateral eye macular hole. If there is a VMA which you can detect, you can tell them that there is a chance you might up to 42%. So the current management of VMI diseases is either you observe them and you observe mild asymptomatic VMT, so you don't have to rush into surgery, tell the patients to observe. Or even small full thickness macular holes, patient vision is still relatively good. You can always follow them closely and then tell them to just watch it, because it may or may not progress. Although in general, macular holes do progress. Of course, you can vitrectomize, and of course, we talk a little bit about pharmacologic treatment of VMI disease. So these are the algorithms. Just summarizes what I explained earlier. So pharmacologic vitreolysis was first defined defined and coined by CBAC. So in the 1970s, and basically throughout this last 20 years, we've been trying something that we can just inject in the eye and then can cleave all these vitreomacular adhesions, then we don't have to do any surgery, okay? And there are many types of agents, interfactants, liquefactants, combination, and then enzymatic and non-enzymatic agents. So of course today we already know, we know that the only FDA approved one is oxyplasmin, which is a recombinant truncated form of human plasmin, because human plasmin is difficult to get to filters, and so this is a synthetic form. Right? So it's a DNA molecule which is more stable than plasmin, and it's a vitreolytic agent, and it is a protease against fibronectin and laminin. So this is the molecular structure if you learn about it. And basically we are using oxyplasmin based on the results of the 3 trials, in 2 phase 3 trials, the MIDI-6 and MIDI-7, and which are both multi-centered, randomized, controlled, placebo-controlled, double-mask studies about the efficacy and the safety of oxyplasmin. So there is a MIDI-1, of course there's just a phase 2 safety profile, MIDI-2 and MIDI-3. Patients at the same dose. This has been found to be the most effective without inducing side effects. So the inclusion, of course, diagnose DMA with OCT, good vision, exclude those with brow vitrectomy, laser, or any macular hole was large. So included cases both for epiretinal membranes as well as macular holes. Check them and look at the effect of the oxyplasmin at 1 month. 28 days is chosen as a pharmacologic resolution of any vitreomacular adhesion at day 58, because beyond that it's unlikely that there will be any more effect. Okay? But there are some secondary endpoints. And basically, I know these numbers don't look fantastic. I mean, you already read it and you must have already heard. But you must remember these are the early trials when they only include all patients, all sorts of vitreomacular adhesion, all levels of epiretinal membranes, macular holes up to 400 microns. We know that some of these cases are not the ideal cases for treatment. So, but still, there was statistically significant difference between oxyplasmin and placebo in terms of VMT resolution, 26%, EVD induction, 13% compared to 3%, and macular hole closure, 40% compared to 10% placebo. So, based on these results, oxyplasmin was approved for clinical use, and this is just a summary of that. So proportion of all patients is non-surgical over the course, and you can see that most patients, over 70% of responders had DMA resolution by day 7. So if it's going to work within the first week, you will know that it's going to work. And after 28 days, it's very unlikely it's going to work. Okay, all right. So that's the end point. So subsequent subgroup analysis showed that the best candidates that had a higher success rate of up to about 50% on the average are those younger patients where there is no significant epiretinal membrane. The phakic eyes tended to do better. Vitreomacular traction again is more focal, less than 1500, and for macular holes, less than 250 microns. So these are the best cases with better results compared to the ones. What about safety profile? Again, of course, there have been there have been many reports about the visual disturbances when you inject oxyplasmin. So you have ocular adverse events. What is much? There was no statistical significance difference between the placebo and oxyplasmin group. We know that there are adverse events that have been reported. Patients will complain of bloaters, autopsia in the first day or two. That's why they say you never inject the patients on Friday, because then over the weekend you will receive a lot of calls of patients having bloaters, flashes of light. issues with oculoplasmin in terms of loss of best corrected visual acuity, dyschromatopsia, something people think that because of direct retinal toxicity, although it's never been proven on the ERG. I've talked about the OASIS trial, but these are those splashes of light are very common. What about loss of vision? So ERG changes in the form of reduced A and B wave amplitude were reported in patients experiencing dyschromatopsia and transient loss of vision, widespread retinal dysfunction due to the effect of the oculoplasmin on the laminin, which is present in all layers of the retina. So as you remember, the oculoplasmin will go right through all layers. So the OASIS, however, particularly studied the ERG comparison between the sham and the oculoplasmin treated cases. So between, again, it is 146 patients receiving Vitreomacular or oculoplasmin and 74 given a sham injection. And evaluated. So OASIS met its primary endpoint, right? So this one, the higher because you chose the patient more carefully, and you had 41% success in achieving VMT BMA resolution at day 28 compared to 6%. Huge statistical significance. So it was even higher in oculoplasmin treated patients without an epiretinal membrane, as you understand, about 50%. And in terms of the quality of life score, they also studied the effect of oculoplasmin in treatment of the vitreomacular disease using a quality of life visual scoring. They were much higher proportion that were better in terms of the oculoplasmin. So there were no new safety signals, and ERG changes after injections were transient and not associated with long-term effects on visual acuity. Okay? So we used we had some limited experience because we have oculoplasmin. Is oculoplasmin available in what countries? Anyone has any experience? Okay. So yeah. So I think we also reported about a 50% success, although it's a very small series. We had 6 cases, and then there was some problem with the oculoplasmin, and now very much we have not continued using it. So variable success, so like this VMA, because this was in the fellow eye of a patient with a macular hole in the other eye, so she was keen to, because there was a definite VMA, so she was keen to try to prevent that. We gave it, and that worked. Retinal membrane, this was a patient who was very knowledgeable. He even knew that there's such a drug, so he said, I want to do something. Although he didn't really fit the inclusion criteria, his adhesion was quite broad, more than 50. Again, and of course, that didn't work. He didn't lose vision. This VMT didn't work. I think it was a little bit chronic. The macular hole didn't work, although it looks like a small hole. This VMT, very adherent. This macular will work in terms of, so 50-50, your salvations. If you don't work, then you have to consider surgery, okay? That's up to the patient whether you want to use more. So imaging advances increase our understanding of EMI disorders, and we all know that OCT technology continues to improve. We get better and better in terms of resolution, speed, and then we can start to see the changes better. Oculoplasmin is effective, but not perfect. So in terms of, okay, you failed, I mean you tried, so assuming you can get oculoplasmin counsel. So you have 50%, okay, then we have to talk about surgery, all right? So micro-incision vitrectomy surgery, as you know now, has changed rapidly over the last 20 years in terms of techniques and in terms of its instrumentation. Is very important because in the past, nobody thought that the macula could be an area that we could actually operate on, but now with all these advances. So of course, you know that now we are using smaller and smaller gauge. Of course, now we started using 27 gauge, especially for macular diseases. It's quite appropriate. 27, maybe how many do 27 gauge here? 25? 23? So you're somewhere in between. So you have to move down. Go smaller. Alright, we all know why we are doing 20 small gauge. But It's not just one instrument, it's a whole host of instruments that you have. So that again, you have to study whether it is cost effective and all that. Because these are very delicate instruments. It's not something that you can reproduce easily. So you can't just start a case small and then you want to change. You will run out of one instrument, you can't. So you're going to have everything available. So epiretinal membranes are definitely something that we deal with a lot. Most of them are idiopathic, so of course you have to always look for other causes, and we always teach the residents that we see an epiretinal membrane, let's look for retinal tear, sometimes associated with retinal tear. I think all this knowledge is very clear. We used to do FA and look at the now I think with OCG, that the diagnosis is usually very straightforward, and it's something that you can actually show and discuss with the patient. You see, this is before you had surgery and this is after you had surgery, so you can actually show the patient in terms of anatomic structural improvement, whether they improve subjectively in terms of vision. I mean, most patients do, but some patients they still feel that, of course, the visual depends on the type of ERM. So when should we consider surgery? When there's loss of best-corrected visual acuity, you can advise a patient. After a certain time, the visual acuity will decrease up to about 18-24 months. And after that, they probably will stabilize going forward. So if they are disturbed any time between that, you can consider surgery. There's marked metamorphopsia or diplopia, depends on the location, and you have to assess each patient individually. The thing to note is that the visual loss is not exponential. They rarely worsen after the initial diagnosis. You don't have to push the patient to operate. You give them time to think about it. Yeah? And of course, if the patient is keen, you do it early rather than late, because the early treatment, because we're able to do it safely now. Always the visual results will probably be better if you do them early, and that's been shown in numerous studies. Some people operate at 6.9, 6.6 level of visual acuity. My cutoff is probably around 6.12. That varies. So what are the goals of vitrectomy? So we remove the epiretinal membrane. Relieve the macular distortion. So now we have advancements in a lot of these instruments. We used to use brush to help us, but now with visualization using good viewing systems, clear media, and of course we help a lot by using dyes and stains. So this is 27 gauge. You will know if you are an Alcon user, you will know this is 27 because of the pink color. For the ladies, they like the pink color. So this is 27 gauge. The cutter is pretty stiff. It's not like all these. These are the 27 plus. It's stiffened so that there is. These are valve cannulas, so you don't have to worry about leakage. And again, this is the dark pink that they use to identify the 27 gauge, which you will see very soon. There is a 27 gauge here. Plus. Okay. So I use a new kind of dye called triple dye, which is a lutein-based dye. It combines everything in one. So you have a vitreous lutein, which is a natural occurring pigment. So I don't use triamcinolone now. So I use this. So it stains, and then it has trypan blue and brilliant blue. So it stains the epiretinal membrane, and it also stains the eyelid at the same time. So with 27 gauge, it's a little bit slower in terms of the efficiency. Not particularly, but use a little bit slower compared. If you are used to a 25, it is a little slow. If you are doing 23, you will definitely feel that it is slow. So again, you need to have the full set of instrumentation. You have the forceps as well, the 27 gauge forceps to peel the membrane. So certainly for macular diseases, 27 gauge is eminently usable. You have to have all the correct instruments, as I mentioned. And sometimes if you can't peel it from the island completely, you can use actually the protector, because the port is very close to the tip, as you know. It's small gauge instruments. You can engage the epiretinal membrane and use that as an instrument rather than having to use the forceps all the time. So what to tell your patients? I think you can tell safely 60–80% of your patients should improve visual acuity at least 2 lines, but you've got to wait, sometimes takes 6 months or 1 year. You will get the cataract, so most of the time in patients who are above 50 years of age, we will do combined vitrectomy so that we reduce the need for a second operation. In terms of macular hole, I think we all know the clinical features of patients. Idiopathic macular hole, we're not talking about myopic macular holes. It's the idiopathic, healthy, normal eyes, and more common in females. It goes through various stages, but invariably macular holes do progress. So if you follow the patients over 3–6 months, usually the hole will progress. And of course, we mentioned about this is the original classification by Dr. Gas, and we've been using for years and years until the new BMI classification. And certainly that shows. So there are many theories. Again, I think all of them probably apply, but again, it is due to the vitreomacular anomalous perifoveal separation that results in macular hole. So of course we know that previously thought untreatable, but now we can close these macular holes in up to 95 or even up to some people 100%, depending on which cases you choose, I suppose. And now again, it is basically an OCT diagnosis. So we've been doing macular hole surgery for obviously over 20 years now. The initial cases were not so good in terms of success. At that time, maybe say 70%. I think. So early holes definitely don't do anything. If you have oculoplastin, you might consider, but there's no certain. You don't have to do it because some, like I said, the natural history they might abort. So 40–60% will abort. So the initial Kelly and Wendell report in 1991, when they just created a posterior vitreous detachment and gassed the eye, got 58% success. That prompted many people to start doing macular hole surgery, and then of course there have been many modifications along the way, which I'll discuss, right? So you use small gauge, 23 or 25 or even 27 gauge is eminently possible to do. We discussed earlier on about ILM peeling in detached retina. I'm just showing this. This is not an idiopathic macular hole. This patient had a macular hole. So I think if you have a detached retina and you want to peel the ILM, peel it under peripheral. Haven't tried this? So you flatten the retina, put some dye. As in this case, I use a membrane glue, and then you can peel the ILM under peripheral. It's much easier than trying to peel a detached retina. And in this case, I'm doing partial ILM peeling, or what we call ILM infolding. So you basically peel the ILM towards the macular hole and then just stuff it into the macular hole and don't remove it. That's been quite useful in myopic macular holes and larger macular holes, idiopathic macular holes. I do that routinely as well. So I don't remove the whole ILM. Of course, we use some people air, some people SF6, some people C3. That's preference. So you can see the blue tissue is this patient had a peripheral, another chain. But you can see the blue tissue is the stained ILM, which I'm not. You just drain it and keep that ILM on the macula. So one important advance with the OCT as well is that we can predict now. I can tell the patient on the first day after surgery, you do a post-op OCT using one of the under the hydrophone, but this is with the popcorn, the strep sauce. You can actually tell the patient on the first day that the macular hole is already closed. So you don't have to wait 3 weeks to say. And then once I see that the hole is closed, then I'm not so obsessed about the posturing. But just tell them to keep their head down for a while. You can see this is 1 day after surgery. You do an OCT and through the gas. You can see. So if you have an OCT machine, just try this if you do macular hole. If you have a full field on the first day, just do an OCT. You can tell whether it's operation. Of course, now we have intraoperative OCT. That might even be better. Just do it on the day. I talked a little bit about combined phaco vitrectomy. Again, in general, most patients above 50 will do combined phaco vitrectomy. I'm sure you all do combined phaco vitrectomy here. Because it allows a more complete volume of gas. And maybe you don't have to enforce strict posturing so much. And you don't have to worry so much about having early cataract, or which disturbs your vision of your view of the retina. All right. So intraoperatively, again, it's better to see, and you can see clearer during surgery. You don't have the lens disturbed. You don't worry about hitting the lens. So you plan to have to do the vitrectomy at the same time. Right. Of course, in terms of cost, definitely it is more cost effective because you only need 1 surgery instead of 2. So over the years, there have been variations of the technique. You have adjuvants in the early years when we started, people putting enzymes, putting serum. More recently, the Lai Chi-chun from Taiwan, they use autologous blood. So they take blood and inject over the macular hole. It's been reporting good success with that. But of course, nowadays we all do island peeling, and again, I do island peeling routinely in all macular holes. The extent and the technique of peeling, again, it's very individual. Some people, for bigger holes, I will not remove, I will do macular infolding, island infolding, don't remove the island. And then whether you took air, gas, or how long you need to posture, no posture, there are many forms. So, well, if your surgery is successful, I think with island peeling, we've seen very little. The only change I noticed that we have very little late reopening. In the early days, we reported up to 5% of macular holes reopened. They reopened. So far, we've had very little. So what can you tell? I always tell, but never 100%, although close, but not 100%. Okay, so say 90%. You improve vision, average 50%, and then warn them about the fellow eye. And you need to follow them. So, again, like I said, consider phaco vitrectomy. If you don't, then you need to reoperate if the patient develops a cataract. Of course, there are other risks related. If you don't do a good peripheral vitrectomy, there is secondary retinal detachments and retinal tears that might complicate the surgery. So, I won't do any hole that is, people report other ways of treating big holes. Taking ILM and then covering the hole, or they take lens epithelium and put on the hole to cover big holes. Big holes are a problem. In general, I find that the results are not very good with this. So anything above, like I said, for 500 is probably my limit. And if it's for there for years and the patient is not symptomatic, the other eye is good, and there's no real need to operate. ILM removal, we know, improves the rate of success. It's been reported in many papers. So whether you stain or you don't stain, I routinely stain because I think that's the most sure way that you have removed all the necessary ILM. You do not need to remove very much, completely, but depending, I remove the amount depending on the size of hole. For smaller holes, I just do a small ILM peel. The larger holes, I try to make as large a peel as possible. Of course, there are many agents you can. So there are basically two considerations in terms of the patient and as well as the surgeon. Right? Patients they need to be motivated. They need to understand what is the condition, what kind of realistic expectations they can expect, cost benefits in terms of having the surgery or just following up. You need to counsel them completely. As for the surgeon, of course, you need to be trained. You need to have access to the proper instrumentation. You need to modify according to your own experience or what you have learned to achieve less complications with surgery. So again, just a summary in terms of, so everything must fall in together. You need to have do the surgery, combined vitrectomy. You need to remove as much of the vitreous completely using the stains and removing the island, and then explaining to the patient the kind of dyes that the type of gas they need for posturing. So you modify your posturing according to the type of size of the macular hole. And like I said, if you have access to high quality OCT, you can use it to guide. So every visit you find the first day is closed. If after a week you find the macular hole, you scan again, the macular hole is closed. Basically, that hole is closed after the first day, so you don't need to worry about that. All right, so instrumentations and techniques have greatly influenced the advancement of macular surgery in the last 10 to 15 years. The results of macular surgery improved tremendously, so it's something we've been doing more and more over the years. The percentage of cases requiring, in terms of overall vitreoretinal surgery, definitely is increased. Improved macular pucker and macular hole surgery, and get very good outcomes in good hands, right? Very minimal complications, right? So the only way to do that is through innovation and, of course, proper training. Thank you for your attention. I invite you to Singapore again for the APO meeting in March next year. So we have maybe 5 minutes or questions. So you have to bear with me for another hour.
Okay. For the case of some kind of diabetes or secondary ERM from RDO, do you consider the IOM healing, and why?
Secondary case of?
Maybe secondary membrane or
secondary membrane, yes.
From RDO or diabetes. It is useful for membrane healing, IOM healing.
Yes. In general, I do IOM heals in all cases of epiretinal hemorrhage. So whether it's primary ERM or secondary diabetic, RDO, because I think that's the only way to prevent recurrence. The ILM is like a scaffold for recurrence. So this is the only way to make sure that almost 100% you will not get the recurrence.
And your current practice, do you prefer to inject the gas or air or nothing?
I still use gas. I don't use air. I still use gas. The shortest majority of the cases are SFCs, unless it's a very large hole, and I'm not sure how good. I want longer temporal to be sure. Then I might use C3F in some cases. In general, for the small and medium-sized holes, I just use SF6. So small holes, I will peel everything and close the hole on the table. You can do that with a small hole. Just put the gas, and you can gently oppose the macular hole. Then you know that it's closed on the table. For stage 2, I will do infolding. I will not remove all the island. I will fold the island over the macular hole. Just drain the fluid over the optic disc. Because once you fold the island, you cannot drain the island. You cannot drain the macular hole because the island will tear. So just drain the gas, the fluid over the optic disc, away from the macular, and then just gas it, and that works as well. And of course, for the big ones, either macular folding or partial island healing, and then long acting. But it's not really proven any, it's more through personal experience. I can't quote you any study that says that. If you you listen to most experts, that's what the consensus will be. In terms of the error, yes.
Và tôi câu hỏi.
No, yes.
Trong trường hợp mà lỗ hoàng điểm chấn thương đó, thì khi nào phẫu thuật?
The question is traumatic macular hole. I think looking at most of the time they will either present very early. They usually don't present early with the macular hole. Usually they present sometime after the trauma, and it's usually young people with traumatic macular holes. Those cases that I have done, as long as there are no associated injuries and the peripheral retina, everything is quite. Surgery can be done at any time. I suppose the earlier the better. Try to get better visual results.
Câu hỏi thứ hai nữa là trong trường hợp là lỗ hoàng điểm lớp lamella hole đó thì ông phẫu thuật không?
So it all depends on the. Well, you have to be very clear the distinction between a pseudo hole and a lamella hole, and the classification will tell. The OCT will tell you whether it's in a pseudo hole or a lamella hole. Pseudo hole, you know, is actually a thickening of the epiretinal membrane. The underlying retina is actually normal. So you have to be very clear in terms of the OCT to be able to distinguish, and also based on the symptoms. Yeah. So in general, if it is just a pseudo hole, I will not offer. But in some lamella holes, if the patients are symptomatic, or if it's a fellow eye already not good in terms of having a same, maybe a full thickness hole before, and the vision already affected, then I might do that earlier. Advise surgery to get the normal structure. So you have to distinguish, is it a pseudo hole or true lamella hole? So there is some, I would say 50-50 in terms of whether you would operate on the lamella hole or not, based on the symptoms, the age, and these things.
Tôi muốn hỏi kết quả của ông về cái điều trị lỗ hoàng điểm và sử dụng ILM inverted flap thì liệu nó có tốt hay không, và ông đã áp dụng cho những trường hợp lỗ hoàng điểm lớn hơn bao nhiêu micron, và cái đường kính đấy là ông tính là đường kính đỉnh hay đường kính đáy?
Okay, well, size again we've already seen in the new classification. So anything above 400 is considered large. Okay? And you measure at the smallest diameter in the middle of the retina, not at the top and not at the bottom, in the middle, at the narrowest part of the hole. So you use that as the measure of the size. So my cutoff is very strict. So anything above 400, I would definitely do macular infolding, and I will not peel off the entire ILM. So, and basically, and also for failed cases of macular hole surgery. So sometimes operation done and then it's failed, the hole is there, and usually in failed cases, the holes get larger. I think all of us have failed cases, and they actually become bigger than the original size. So for failed cases, that means reoperation, definitely I will do infolding. And I've done, I can't tell you how many, but maybe half a dozen cases with that. And the results are much better. So if you have a large hole, I advise you to try partial peeling and fold the ILM. Do not peel it up.
Và cái thời gian nằm sấp của bệnh nhân thì là thông thường ông để bao nhiêu lâu?
Well, like I said, now with the, if you do the OCT under gas, do the OCT and see if on the first day or first week you can show that the macula is already closed, then I'm not too worried about posture. might still use long-acting gas, but I'm not too concerned about posturing. So as long as the patient sleeps on the side, that's fine. So with post-op OCT, you should try that again if you have not done it. I advise you to do that. So you have a very clear view. The lens is, that's why you have done the phaco-vitrectomy, no lens. You've taken away the whatever lens and have an implant, and then you will get a very nice OCT. You see. So if the OCT shows it's closed, don't worry about the posturing. Just limited posturing.
Và theo kinh nghiệm của ông thì là trong số những bệnh nhân của ông thì những người mà đóng dấu hoàng điểm muộn nhất sau phẫu thuật khoảng bao nhiêu lâu ạ? Bởi vì thông thường tôi thấy những trường hợp mà đã thành công rồi thì ngay trong ngày đầu tiên, ngày thứ hai là lỗ hổng điểm đã đóng rồi. Tuy vậy cũng có một số trường hợp tôi theo dõi đến vài tháng sau lỗ hổng điểm mới đóng. Vậy thì theo ông lúc nào thì mình nên xem xét lại xem là liệu là có nên can thiệp tiếp hay là không?
Yes. In general, if it doesn't close within the first few days, it's not going to close. And once the gas goes away, it will never close. Right? So if it doesn't close, by the time the gas clears the macula and you see the hole, then it's unlikely the hole will close. And I will usually tell the patient the hole has not closed. We may need to reoperate if they still are keen to try. But it will not close after a few months, for sure. So if it doesn't close, by the time the gas is gone, it's not going to close. Wai Ching, you agree with that?
Completely. Yes. I think that once the gas is gone, there's almost no reason why the whole post continues at that point. And so, depending on the type of gas you use, so if you use SF6, you only have about 10 days. If you have 6VLA, you have a little bit longer. And then if you see the hole hasn't closed, you might, and you have 50% gas bubble, you may try to get different positions. And that sometimes could help.
Some people report just doing a gas bubble, increase it again, posture. Some people have reported some success again with that. So it's hard to say. But in my experience, I don't bother to re-gas. Do you re-gas your eyes? No. Okay.
How about the overall skis in a myopathic patient?
Yeah. Okay, that's a totally different topic. We can talk 1 hour on that. Yeah. Again, but the techniques are the same. So if it is in general, if it's schisis and there's no hole, then I just peel the island and just put gas. I still gas. I know some people don't gas, but I still gas. But if there's a schisis with a hole and a detachment, then I do partial island healing and gas. Yeah. That's myopic surgery. Schisis surgery is totally different because it's so much more. The retina is so much thinner, the island is so much more difficult to visualize, and you really have to be very skilled to be able to treat species. One last question.
I just want to confirm, you said that you don't perform surgical for pseudo-hole, is that right?
Pseudo-hole.
Why?
Also, it is not symptomatic, right? You're saying that,
Yes, symptomatic.
Yes. There are a lot of pseudo-holes that are not symptomatic. Patients have good vision. But actually, as a rule, they have good vision. So it's because of the crack in because the outer retina is usually all intact.
Thank you.
Okay, last.
Tôi muốn hỏi ông, tôi có một cái bệnh nhân bị lỗ hoàng điểm chấn thương và sau đó đã mổ các cái móc hàm và sau khi mổ xong thì là lỗ hoàng điểm không đóng ạ. Thế và sau khoảng độ 1 năm thì lúc đấy thì tôi mổ lại thì không còn màng nào để móc nữa. Như vậy tôi chỉ thực hiện trong một ký dịch mà thôi. Nhưng ngay sau đấy thì lỗ hoàng điểm phải đóng lại ạ. Vậy thì theo ông thì kinh nghiệm của ông trong việc mổ phẫu thuật lại cho bệnh nhân lỗ hoàng điểm là bị thất bại thì như thế nào?
So usually I try to reoperate within 2 to 3 months, or definitely before 6 months. Try to because, like I said, if you fail the first time, the hole usually gets bigger and larger. I always, if the patient is keen, I would say that you want to do it early rather than wait. Now, of course, you also have to understand the patient's psychological trauma, posturing, and after that, they are told that the hole is not closed and they go through the operation again. So it's a delicate balance. But certainly, anything below a year, I think it should be fine. You can read and try, but you don't have too great expectations about the visual results. So either they might improve a little bit or stay the same. Okay, let's move on to the next topic on the lens and IOL complications. I would like to discuss specifically about drop nucleus during